Hi, this is Ellen Polishuk, and I'm really pleased to have you all join us today for Laura Gottlieb's presentation, What Can the Healthcare Sector Do About Patient Social Conditions? I had a sneak peek at the slides, and I know that you're in for a real treat today. So first, a few housekeeping items before we begin. Please make sure your mics and cameras are off, except for presenters and interpreters. Please use the QA box on the toolbar for questions rather than the chat box. We keep the chat for interpreters and technical issues. And I'll ask your questions of the speakers during the QA portion of the talk today. At the end, there's a few ways to provide your feedback and make sure you can get CE credit using an evaluation form. Steve will post a link in the chat to the form. There'll be a link at the end of the presentation, and an email will be sent out in the next day or so. So now it's my pleasure to introduce you to Dr. Laura Gottlieb. She is Professor of Family and Community Medicine at the University of California, San Francisco. Her research explores healthcare sector programs and policies related to identifying and addressing social risk factors in the context of care delivery. She is the founding director of the Social Interventions Research and Evaluation Network, a national research translation and acceleration network that advances research and practice focused on healthcare strategies to address social adversity. If you aren't already familiar with SIREN, it's a terrific resource, and I encourage you to check out the website at sirennetwork.ucsf.edu. Dr. Gottlieb is also an associate director of the Robert Wood Johnson Foundation Evidence for Action National Program Office. I'm thrilled to have Dr. Gottlieb join us today to talk about what can the healthcare sector do about patient social conditions. Thank you, Dr. Gottlieb.
Thank you, Ellen. I'm so happy to be here today. I feel like this is a long time coming. I cold called Ellen more than a year ago and asked her to present to SIREN because she has done such foundational work in this area. And from that, we've been able to stay in contact, and it is so fun to now be able to present to you all so far away. And we actually thought, well, maybe the pandemic will be over and I could come out and meet you all, but sadly this is virtual. But thanks for joining today. I'm Laura, and I do still work clinically at the county hospital here in San Francisco, but mostly I get to do all this fun work kind of connected to Ellen's work, really focused on the intersection of social and medical care delivery. So that's what we're going to talk about today. There will be plenty of time for questions at the end, if all goes according to plan, I guess. So let me just start by acknowledging out loud something that I'm guessing that everyone attending today's session already knows. And that is that social determinants are really in vogue in the US healthcare sector. So as many of you probably know well, questions about our social care roles and responsibilities have really become the central focus, not only of healthcare-based reports, papers, conferences, but also many clinical innovations, and now both public and private payment models too. There is so much happening though that sometimes it feels a little bit like you could be crushed by the massive social determinant snowball coming down the very steep hill. And as I mentioned, this is the focus of my research and policy work, and I think that's why Ellen wanted me to share that work with you today. But if you believe all the reports, webinars, conference papers that we get every week on social determinants of health, you might believe that assessing and addressing social risks within the healthcare delivery system is going to fix all that ails the US healthcare system. I am from the Bay Area, so we put everything in startup language. I like to say that this is because we are at the beginning of what in technology startup world they would call the peak, we're at the beginning of an innovation hype cycle, which usually starts with this peak of inflated expectations and is followed by a deep, deep trough of disillusionment where early innovations don't consistently deliver. And I like to think that our goal as researchers in this field and consultants is just to make the trough a little bit less deep or deep and the slope of enlightenment a little bit steeper so that we reach that plateau of productivity where we find innovations with staying power a little bit more quickly. Okay, I'll leave the innovation hype cycle alone, but I will point out that then along came COVID, which really accelerated both interest and innovation in this area by underscoring the very powerful and devastating intersections of health and social adversity. So in the acute pandemic setting, as you must know, we've seen changes in the acceptability of social risk screening and intervention. So we've seen a lot more attention to screening for homelessness, expansion in food security screening for people trying to quarantine. We've seen food delivery service interventions increase. We've seen more childcare screening, digital access screening, and related interventions. And I think the key question here is, could the healthcare sector actually sustain these kinds of innovations in the context of the longer term poverty epidemic that is likely to be with us for a lot longer? So if the tragedy of COVID alone weren't enough to accelerate our interest in healthcare social care practices, it also magnified our health inequities by race and ethnicity in a way intimately tied to social determinants of health. So all that to say, there just has never been a greater interest in or need for rapidly figuring out what we're going to do to strengthen work around social adversity. So with that background in mind, my plan is actually to use our time together to share with you work that I did as part of a 2018 to 19 National Academies of Medicine committee that was focused on this title, Integrating Social Care into the Delivery of Healthcare to Improve the Nation's Health. So the report is publicly available. It was published in September 2019, which already feels like a long time ago, and yet just yesterday. So I like to present on this report because I think it provides a useful organizing framework for us to categorize the different types of healthcare activities around social care that we've seen rise up in the last decade or so. So essentially the goal of the committee was to explore how healthcare could both acknowledge and intervene around social conditions. As we explored this topic, we did our best to be consistent about the language we were using because there is a lot of overlap in the words being used to characterize efforts in this field. So for instance, we tried to emphasize that social determinants are just one part of what shapes health, whether for individuals or communities, and it's not a synonym for population health, which is really a result of a combination of social determinants and many other factors. Similarly, in our effort to create kind of a shared language, we highlighted how social determinants themselves are neither good nor bad. They just are. They're like the air we breathe. Some are health promoting and some may negatively influence health. Additionally, we tried to distinguish between upstream social determinants of health and more downstream social determinants, which in this talk I'm going to refer to as social risks, social assets, and social needs. So more upstream drivers might be government, institutional policies, economic policies, but the more downstream ways are the ways in which those policies and practices manifest in concrete material assets or risks. So, okay, so a lot of background, but as I mentioned, the core of the committee's report was really a framework defining 5 different ways in which the healthcare sector is already engaging around social adversity and social asset building. And these are categories where we may already be working, but where we also could strengthen social care to improve health. So again, it's just an organizing framework. It works for a lot of things. It may not work for everything, but I think it again is sort of this effort to build a common language to think about the different categories of activities, even though the actual activities under any one of these buckets may differ quite a bit. So let's march through these in a little bit more depth, starting with awareness activities or strategies that healthcare systems use to collect information about patients' social conditions. So again, this is a bucket that includes a lot of different activities, but all about building awareness or recognition of social context. The initiatives under this bucket might include ways in which patients are just asked about their social risks in the context of clinical care delivery, or in health risk assessments that are administered by insurers, for instance. There are also some systems that are buying big consumer data about your purchasing history, your home ownership, or your history of bankruptcy to inform their actuarial assessments, so how likely you are to cost them money over time. There are other health systems that are mapping area level socioeconomic data and crossing those data with patients' addresses in order to get information. So you can see there's sort of a big diversity of different kinds of activities already underway in this area. At the individual patient level, much of the research that's happening on awareness has revolved around these new patient-focused social risk screening tools that have been endorsed by groups like the National Academy, the American Academy of Pediatrics, the American Academy of Family Physicians, the National Association of Community Health Centers, et cetera. So as many of you know very, very well, there's actually been kind of a vexing lack of consistency across the different tools. I just pulled three of the kind of three most common tools that we've seen develop in this area. But they don't include the same social domains or even the same measures when they do contain the same domains. They also differ considerably in length. And on the side of this slide, I actually have a resource, a free resource for people who are interested in just looking at a number of the most common tools. I think we now have 20, 23, something like that, different tools on our website so that you can look at the actual measures used in each of these tools. Oh, and I have a slide about that too. So it's just a comparison of these tools. We have one comparison that has adult-facing tools and one for peds-specific tools that have emerged in this space. Our colleagues in Seattle and Portland have done some really interesting work demonstrating that none of these tools has actually been developed using kind of gold standard measure development for multi-item tools. And in the absence of a standard, what we're finding is that many people are modifying existing tools. So even if people say they're using the Accountable Health Community screening tool that CMMI put out as part of their demonstration project, people might be using a piece of that, but not necessarily the whole thing, or changing some of the answer items in select questions. The reasons for these modifications really vary. So some people say that existing tools don't adequately capture the risks that are relevant to their population. Other people have said that they recognize that taking a collaborative approach to developing the tool actually builds buy-in in their institution. And then some are hesitant to screen for risks that they don't feel like they can help with. And we can talk about that later. But I think the point is that the lack of a strong mandate from either federal or state institutions to use a specific tool has really contributed to this customization. What we do know is that the modified tools don't have the identical psychometric properties. So if you change the response options on a question, for instance, you may be capturing very different information and have sort of a changed sensitivity, specificity, or other components of validity. Many of the studies on social risk screening have surfaced some intriguing differences between the number of people who endorse a specific social risk on a screening form and the numbers of people who are interested in receiving assistance from their healthcare teams related to that topic. And that might be for all the reasons I just mentioned around the validity of the screening items. But as a result, some of the existing tools now include a question akin to, would you like help with any of these risks? And interest in assistance has really ranged from 0 to 100%, depending on the context and the risk factor. And for me, this also raises some important questions about whether there may be some specific patient characteristics that are driving interest in assistance. And more specifically, whether overlooking those differences might mean that social risk screening and assistance could worsen disparities by race or ethnicity or language or some other factor that we're not accounting for when we look at this difference. So for instance, if people who have a particular characteristic, so people who have experienced discrimination in the healthcare sector are consistently uncomfortable answering questions about social risk screening, we need to know that and we need to look into it. We need to change the strategies that we use to ask questions about social risk. So in part to help explore some of those questions, we conducted a 1,000-person survey, including 10 different clinical sites around the country, including pediatrics and adult, primary care, and emergency room settings, where we actually asked patients about whether they considered it appropriate to be asked about social risks in their healthcare setting, whichever healthcare setting they were being seen in that day. And moreover, how comfortable they were with having those data about social risk being incorporated into their health records, into the electronic health records. So you can see from these pie charts that the majority of people are either very or somewhat comfortable with both of these topics. So we saw no differences in patient acceptability across the two different screening tools that we used. And acceptability was not, in this study, significantly associated with race, age, or gender of the respondents. Just a caveat about this, and maybe a flag for future research, we didn't include psych-specific, psychiatry-specific, or mental health-specific settings, which I realize is of particular interest to this audience. But I will point out that psychiatry has historically more routinely considered social context and clinical encounters than other disciplines. And the APA practice guidelines for psych evaluation recommend social risk evaluation or more info about social histories at the very least. So it may be that patients in mental health settings are more comfortable answering these questions, but that is a flag for you all for future research. So given that the tools exist, they're incorporated into electronic health records, they're generally pretty acceptable to patients, you might then wonder about the extent to which social risk screening is happening in healthcare settings. This is a slide from my friend and colleague, Teresa Fraze, who's now here with us at UCSF. Her team analyzed findings from a national survey of healthcare organizations, including hospitals and outpatient practices, and the majority of respondents actually indicated that their healthcare setting was already routinely screening for patients for at least one social risk factor, and about a quarter were screening for 5 of the big ones that have been included in many of the tools. So housing, food, transportation, utilities, and safety. So it depends a little bit on who you ask, though. The extent to which screening is really happening is not as clear. So practices may say that they're doing it, but they may do it for a handful of patients or for a target group of patients. This is work that our team did, just showing the dramatic differences in the results of on the prevalence of screening, depending on who you ask. So we looked at 23 different surveys that were completed by different important stakeholders in the healthcare setting. And you see that if you actually ask patients, only less than a quarter actually say that they've been asked about at least one social risk factor in the course of the last year. So again, this work has not been done specifically in mental health settings. So important work to think about doing in the future potentially. There are, as I mentioned, some really important alternatives to patient-level screening. So some clinical organizations are exploring ways to identify their high-risk patients by using address data. But the use of those data to then guide individual level interventions is a little bit problematic. So this is a slide representing work that we did with our colleagues at Ocean, which is a large integrated Epic platform for over 600 community health centers across the United States. They've been real pioneers in doing social risk screening and incorporating that data into their electronic health records. So in this study, we looked at patients whose responses to a social risk screening form had been entered into the electronic health record, and those patients had geocodable address data, where we could then match their address data with census data to look at, oh, well, what is their social deprivation index? And we found that in 40% of the cases, so that's the highlighted bar here, patients endorsing social risks in the clinic would not have been picked up on using purely address level social deprivation data. So there's a disconnect between the self-reported data and the address level data. Just to emphasize that, it's a little bit confusing about how to use address level data in directing interventions. So we are starting to understand some facilitators for awareness activities. Technology seems to be one of them. As you probably know, I don't know what system you're using there in Rochester, but many EHR vendors and individual health systems have now incorporated social determinants of health modules in their EHR platforms. So this is a screenshot from Epic just showing that you could click on one of these icons, you could get a list of questions related to that topic, and then those data would be stored in the electronic health record. Similarly, payment incentives can also be used to facilitate screening uptake. So this is a slide from a private payer that incorporated social risk screening as a reimbursable quality measure. And I will just say that we've heard from many state Medicaid agencies that are now incorporating social risk screening measures into their, at least into their Medicaid managed care contracts. So I'm going to move on and talk about the next 4 domains. I won't go into quite as much depth, don't worry on them, but I'm going to talk about the other 4 domains in the National Academy's framework, which really all focus on intervention. So now you have the information about patients' social conditions. What can you do about it? 2 of these are more clinical delivery system focused, adjustment and assistance, and then alignment and advocacy are more community level focused. So the first of the healthcare delivery focused strategies refers to situations in which social risk data are used to inform clinical care decision making. At the point of care, could be at the payment level. For instance, we might choose a less expensive medication for someone who can't afford their medication, or we might adjust a quality measure payment based on social risk factors, which are there. You may have seen a lot of discussion about this right now at the policy level. So I'm going to give you a few more examples of this. I personally like to think that this adjustment stuff is work that as clinicians, we do every day, particularly in the safety net, although we just don't do it always that well or systematically. We accommodate social risk factors that could interfere with treatment. For example, we try to improve access to care for patients who don't have great access. We send out mobile vans. We do evening and weekend clinics. We provide interpreters who don't speak the same language that we do, or low literacy materials to patients who need them. We also use social data to inform diagnostics. So as an example, the mini mental status is supposed to be adjusted for literacy level. And if we had the information about literacy level at our fingertips, or a system that built-in system that adjusted for literacy, we might be more apt to use it routinely. We also adjust our treatment plans based on patients' social context. We dose once daily meds to accommodate work schedules, or meds that don't need refrigeration if avoidable for patients who don't have a refrigerator. So a major obstacle to adjustment, which we in previous work have also referred to as social risk informed care, is that we don't do this for every patient, every time. We haven't wrapped a ribbon around these kinds of interventions and protocolized them, studied them, learned what works best and for whom. So in general, we just do this inconsistently. And we do need better evidence to more systematically apply social risk data to improve kind of traditional or conventional care. And then we need to have, as I mentioned, the right social data available to the right provider at the point where they're making decisions. There's a lot of interesting work happening around adjustment right now. I'll just highlight one case from diabetes where Tiffany Vano's team in Michigan has actually looked at, well, how are people already making decisions in diabetes based on information about social risk? And the clinicians in that case reported targeting the level of blood sugar control. So they're changing the goal hemoglobin A1C if a patient has really limited food access. They're changing the type of insulin to make sure that the costs are less prohibitive to patients. They're changing physical activity recommendations. They're trying to adapt healthcare access or referrals based on what works for the patient. I just think it's a useful model for thinking about other kinds of care. So in a depression example, for instance, I'm wondering, like, what changes do you all make to depression care already that you haven't necessarily thought of as adjustment or based on patient social risk data? And could you be collecting data more routinely about patient social risk and using that to inform your clinical decisions? So like in the case of awareness, technology can certainly facilitate adjustment activities. I don't know the extent to which this is actually coming into play in mental health settings, but there are certainly many new technology programs that are really focused on trying to reduce the burden of medication costs, which is such a major barrier to treatment adherence in all fields of healthcare. And this technology is sort of a way that we nudge providers to help them make prescribing decisions that are more responsive to cost issues. So for instance, these real-time pharmacy benefits essentially just provide price checks on the selected medication. And they say, oh, well, there's some comparative meds that may be may have equivalent efficacy that would be less expensive for your patient. Would you consider this medication? But you can sort of see that if this actually works, and there is some question about how effective or how accurate these tools are right now, but they're working on it. But you can see that if this worked and you actually were being shown an equivalent medicine that was less expensive, you might feel a little bit more comfortable asking patients about their financial security because you have an option. You have something that you could do to then respond to their social situation. So beyond adjustment, I think more common in the news and health services research, we've actually heard more about social risk targeted interventions rather than social risk informed interventions. The NASM committee referred to these as assistance interventions. This is where we actually use healthcare resources in some way to improve the patient's social context. So this is sort of the assumption that if you improve the social context, it might improve health and well-being. So instead of using non-refrigerated medications, maybe we would help get the patient a refrigerator. This is happening in lots of different places around the United States and actually abroad now too. So as an example, every patient who is hospitalized at ProMedica in Ohio and Michigan is being connected with food programs. Or Roots Community Health Center is helping patients obtain a living wage job. Under our California Medicaid 1115 waiver, we are paying for housing support specialists. And actually in some counties, they're helping with some housing costs. Again, these are interventions that are sometimes part of care, but rarely routinely or systematically built into practice. So as with awareness and assistance and adjustments, data and technology are driving some of these assistance interventions. And in fact, we've actually seen this whole new technology startup industry explode in this area to help bridge medical and social care delivery. So there is a big unknown here about whether the availability of data about community resources, which is what most of these new technology platforms are doing. They sort of share, if you say a patient has a food insecurity need or food need, one of these programs like Unite Us and Aunt Bertha and NowPow will show you a list of local resources relevant to that need. There's some data gaps about whether those platforms actually lead to changes in health. To to highlight some of the important evidence and important evidence gaps in this area. I'm just going to tee up a few of the promising studies that have emerged in this area, not specific to the platforms, but specific to assistance interventions that may help you think about work that could be done in this area. Not sure. Oh, sorry, it wasn't advancing for a moment. Oh, I should just add that payment can also facilitate assistance, and we have seen some increased payment model demonstrations kind of showing that payment really can spur more activities around assistance. But let's talk about the research. And the reason that I do this is just to sort of highlight that the researchers are really sort of racing to catch up with all the exciting innovation in this area. So I'm going to start with just the point, a big point to just say that there are many studies that have emerged on how social care matters, but there just haven't been, or how social care might influence health outcomes, but there haven't been that many studies that actually use some form of a synthetic or an actual control group to really convincingly show causal impacts of these interventions. The impacts that have been looked at have included sort of patient knowledge about social resources, and then actual social health, physical health, healthcare utilization impacts. In addition to there not being that many with control groups, there just have been almost no comparative effectiveness studies. So the upshot is just that there is a lot of work left to be done, particularly on the health and cost effects of all these different kinds of interventions. So I'm going to talk just a little bit about sort of the evidence with control groups that has emerged just generally mostly in primary care settings, and then I'm going to shift over to some studies that are specific to mental health settings, just to kind of whet your appetite, hopefully, for doing more work in this area. So the first study I'll just highlight is from Seth Berkowitz's team, addressing basic resource needs as part of chronic disease management, where they actually kind of studied the impacts of a very low intensity volunteer-led program called Health Leads. And they actually found significant reductions in participants' blood pressure and cholesterol using in comparison to a control group. Another study by the same team showed that medically tailored food boxes led to reductions in readmissions and healthcare costs for Medicare and Medicaid beneficiaries. And other interesting work relevant to this topic comes from Shreya Kangovi's team at University of Pennsylvania, which is really focused on community health workers specifically. A couple of years ago, she published this great paper just showing a return on investment article saying that as part of their impact program, they found that the use of a standardized protocol for a community health worker that addresses patients' unmet social needs had a return on investment of $2.50 for every dollar invested in the program, which was obviously super promising and encouraging for people who are trying to launch community health worker programs. So let's move on to the stuff that may be a little bit more directly relevant to the mental health clinicians in our audience today. I'm just going to highlight those few studies on depression that have used some kind of a synthetic or actual control group. The first is a study from 3 primary care practices in Philadelphia, which actually showed very promising findings. They combined hypertension and depression care in the treatment as usual group, although it was already an enhanced treatment group for hypertension. And then they added an arm, they compared it to an arm that combined hypertension and depression care, but then also incorporated kind of a social determinants of health referrals program. So it was relatively small. They only had about 50 patients, but they looked at a change in PHQ-9 depression symptom scores. And they found that the patients in the enhanced intervention actually had both improved systolic blood pressure and improved PHQ at about 3 months. So the upshot, interesting pilot indicating that integrated care management actually could both help depression and hypertension. So the second study is also positive, and then I'm going to show you that it's not all positive. It's a little bit confusing, and again, we need more evidence in this area. So this study is from Lisa Cooper's team at 2 federally qualified community health centers in Maryland and Delaware. So primary care clinicians treating depression were randomized to either standard care versus a patient-centered care that incorporated a interventionist that was trained in providing resources for social care resources. And what they found was that for African Americans being treated with depression, who are really the target population in this study, enhanced patient-centered care with social resource delivery resulted in better ratings of care. It gets a little bit more complicated. So this is actually an old study by a former mentor of mine, Howard Waitskin, in New Mexico, who did some work on promotoras. And they actually did not find any quantitative differences in their randomized trial between patients who were in depression treatment being treated for depression in primary care in kind of a standard of care way versus patients who received services from a promotora who was really focused on addressing issues related to unemployment, inadequate housing, and food insecurity. And then, you have this local expert here on this topic of randomized control trials around social care delivery. So shout out to Ellen here for the work that she has done, really trying to fill some evidence gaps in this area. So this is from work that she did with over 200 women from 3 different urban women's health clinics, where patients were randomized to arms in a study that enabled them to compare the effectiveness of a patient-centered intervention with and without social services resource information. And in her study, interestingly, the 2 arms both got better. So they like in the Howard Waitskin study, it wasn't clear that adding work around social needs actually led to improvements. Although in some subgroups, it looks like there may be some target populations that do better with information about social needs. And if you ask me any questions about that study, I'm going to direct you to Ellen. I'm going to make Ellen answer them. So as we're thinking about the importance of strengthening evidence on the health and cost impacts of social care practices, I just want to underscore again that there's some big kind of gaps in the ethics and equity research that needs doing in this field. So just as an example, screening for social needs might actually exacerbate patient experiences of mistrust or perceptions and experiences of discrimination. So how could we build in processes for screening that actually make it more comfortable for patients from different populations? What are our patients' rights around social risk data collection and then sharing, and how do we protect those rights? Like, there's just plenty of good fodder for research here. Around adjustment, how can we ensure that adjustment strategies are not actually being used to rationalize poor care for poor patients if we're going to tailor care to patients' social conditions. So there are just some really interesting topics here that I would encourage people to think about as you're designing your own work in this area. So again, the point is just that there's a lot of room for folks to add to this rapidly evolving area of health services research. Okay, so I did mention that the National Academy strategies, kind of the first 2 intervention categories are really focused on what healthcare clinical teams could be doing, but I would be remiss if I didn't also mention that there were 2 categories that the National Academy mentions that are really about exploring the ways that the healthcare sector could be an ally, could better align their internal work and their external work to improve community level conditions and strengthen social resources at the community level. So I will say that in these 2 categories, I think the committee really recognized that in this work, healthcare really needs to be a partner rather necessarily than a leader for that work. And I'll give you a few examples. So one place to learn about really interesting work in this area is the Healthcare Anchor Network, which is really trying to help organizations align their own institutional practices with community needs and priorities. So as an example, they're promoting these anchor institution strategies that where institutions sign on to fair hiring practices, living wage policies, purchasing locally, and really trying to enhance community development. Programs like the Accountable Health Communities demonstration project from the Center for Medicare and Medicaid Innovation are already using healthcare dollars to align and strengthen community resources. So they have this alignment track in that model that is encouraging health and non-health sector leaders to come together. And it's actually a requirement of the model being paid for by CMS to come together and discuss community level resources. And then certainly we've seen lots of big healthcare systems now investing in community resources. So that includes payers like United, who has put millions of dollars into low-income housing. Kaiser is doing that now, all with the hope that this is going to improve individual or population level health outcomes. So just to kind of put it all together in one slide, I just laid out the 5 different categories here and marched through a food security example. So you could ask patients about food security at the patient level. An adjustment that people often use as an example in this field is based on data from Hilary Seligman's team here at UCSF, showing that patients who are on food benefits who have diabetes on insulin are more likely to be admitted to the hospital for hypoglycemia when food benefits get low because they don't decrease their insulin doses when they're running out of food. So an adjustment could be to talk with the patient about adjusting their insulin doses. I personally think that the assistance intervention here may be more intuitive, which is get the patient's food. So connect patients with food assistance programs, making sure, trying to make sure that their food is more that food is more consistently available to them, healthy, nutritious foods. And then the alignment and investment activity here it ranges widely. So you could co-locate food programs on your campus. You could invest in the local food for your cafeteria. You could share data about food security with your CBO or with other advocacy organizations, including by advocating for larger food benefit packages. So you can see, like, there are lots of different examples. You could apply this framework to almost anything, but just to thinking about the categories, I find very helpful. So I'm almost done with the presentation. So I'm seeing that there's some questions in the Q&A, and I'm happy to get to those. I just do want to emphasize that the goal of the committee was to think about how we might design healthcare to integrate social care. And that was their sort of overarching recommendation. But then they talked more specifically about how you would do that. And that would, of course, involve some massive changes in the distribution of the way we fund healthcare, the technology infrastructure that we have, and the workforce that we need to deliver these kinds of programs. And that's all much harder done than said, much easier said than done. So I'm hoping that this is a good, a launching point for a discussion, not only for the rest of today's session, but then into the future as you all think about the work that you're doing in your own institution and your own setting. So that is my very high level overview of some of the things happening in this space, some of the research in this space. As Ellen mentioned, the Social Interventions Research and Evaluation Network, SIREN, which is the network, the center where I sit, is really designed to get information about this, evidence in this area, about this area of social and medical care integration into the hands of people who can use it. Everything we do is free. From trying to just synthesize and disseminate research to putting it on the website, sending out newsletters about this, offering webinars and workshops. And I really hope that you use our evidence and resource library or sign up for our newsletter to the extent it will be helpful for you. So that is it for the formal part of today's conversation, and then I'll let Ellen take over as our trusted moderator for all of your difficult questions.
Thank you so much, Laura, for that really excellent talk and giving us an overview as we, as in psychiatry, can be thinking about these issues. I think you all can see how much I've had the opportunity to learn from her really important work, and I was excited to have the chance to get to share some of that with you. So thank you for that. And thank you, Dr. Lee and the department for agreeing to invite Laura here today so we can all be learning more about her work together. So we have a few questions in the chat, in the QA. Feel free to add any additional questions you might have. So first is, which ways has URMC made adjustments for patients' social risk factors? And are we as a system aware of the adjustments, if there are any? So a really important question. And I'm glad to say that there is a group working really hard on this within U of R. And so Compass Rose is working on not only trying to help integrate social needs screening into eRecord so that we can increase awareness, as Laura talked about. That alone isn't going to suffice. So then what is the follow-up once those screens happen, and figuring out how to develop workflows that exist to support all of this. So stay tuned, that is coming down the pike. So next, this is great to hear. I wonder about trust. An issue is people not coming in for treatment to begin with because there's a lack of trust in the healthcare system. A really important question.
Yeah. Super important. Yeah, the healthcare system has done a lot to earn distrust. So we have some pretty fundamental barriers, or to hurdle over, hurdles to jump, around this topic. So certainly, the healthcare sector cannot necessarily. I'm just going to go with not take necessarily out of that. Cannot be the sole actor in addressing kind of fundamental inequity in our society. This has to be a multi-sector approach. And then we have to really earnestly assess what we're doing that builds distrust. If we're gonna, even if we're gonna add this, what we think is very well-intentioned social care work to the array of work that we're doing, we have to really question what is making people not come in to begin with, and then what would make people who are coming in, who have experienced or have good reason to mistrust or distrust the healthcare system. So I don't have an answer for that, except to say that it's not only about providing social care; it's about providing really high quality, equitable care with treating patients with dignity and respect. And then we can do these other add-ons that I think so fundamentally shape health outcomes. But yeah, we got a lot of work to do.
Thank you. And thank you for that good question. Here we have another one. What might be examples of healthcare system alignment, advocacy, and intervention upstream for community-wide public health risks related to the climate crisis as a social condition with its current and pending costs downstream, such as from pollution?
This is such a good question, Paul. So one of my colleagues, you're not a colleague, someone I know who I have worked with before. I don't know what defines colleague. Linda Rudolph out here is doing some really amazing work trying to get healthcare systems to pay more attention to the climate crisis, as is Healthcare Without Harm, a national organization that's gotten all of these hundreds of hospitals, I think, to sign on to agreements to purchase food that's sourced locally, as I mentioned, to reduce their waste by X percentage. There are a number of different things on the Healthcare Without Harm and on Linda's recommendations, but those are the kinds of things on the alignment and and advocacy side that they have really been encouraging healthcare systems to think through more carefully. Telemedicine is another example. So, where could we decrease our footprint? How could we, not only decrease our land use, but also decrease transportation and therefore pollution needs related to healthcare. So all of those are examples, but I would definitely encourage you to seek out more information of this from people who are really focused on that area. I'm forgetting Gary's name, the guy who created Healthcare Without Harm. Gary, does anybody know? Something, who's amazing and has really committed his life work to that topic. But it's a good question. There are a lot of resources.
Excellent, thank you. I was gonna ask you, we got to thank you. So I'm gonna selfishly ask you a question of my own since I don't see any other questions in the QA.
Hopefully it's about your study and then I can just send it right back to you.
Yeah, thank you for the shout out. And that is, as you know, I'm interested in thinking about patient preferences and priorities. And you did a really nice job of showing us how patients don't mind being asked about what their needs are generally, but whether they really view the healthcare context as a place where they want that to be part of their healthcare, what kinds of things they want to have be addressed as part of their healthcare. It's a broad range of domains that might be assessed. I think in some ways this links for me to the question about trust as well. I'd like to hear you talk a little bit about that and your thoughts about how we understand what patients really want and respond to that.
Yeah. Believe it or not, Ellen and I did not talk about this question ahead of time, but I love this question because I didn't actually show data from the qualitative side of the 1,000-person survey that we did. So there is a paper on the qualitative results. So we interviewed about 50 patients who had participated in the quantitative survey in those 10 different sites across the country. And we asked them related questions. So we said, is this okay? What's the value of talking about your social risks here in the clinic setting? What's the downside? What would make it feel more comfortable, et cetera. And Elena Byhoff and Amelia DeMarcus, who led the analysis of those interviews, have written a really nice paper talking about how patients that they spoke with didn't actually expect their healthcare clinician to solve for their social risk factor. They wanted their clinicians to know, to understand, and the conditions that they were living in. That response really resonated for me because we had done this randomized control trial. I didn't show you the results of that study, but we'd done a randomized trial in a pediatric specific setting in 2000. We published it in 2016. Easy to find if you're interested in it. But what we found was that patients who benefited from the intervention, so the big outcome in that study was parent-reported child health, general health status. Patients who reported benefiting from the intervention, the benefit wasn't mediated by a change in social health elements. So like if you had food insecurity and then your parent reported that your family experienced food insecurity, your parent reported that things got better, it didn't necessarily mean that things got better through a change in your food security. Which to me, like when you put your thinking cap on in that, like, what does that mean? Like maybe you're providing a social health intervention, but you're not actually changing social health. That means that the benefit's coming from something else. And I don't think it will surprise the mental health clinicians in this audience to hear, I think it's about relationship building. So you ask questions about that are really sort of much more about the whole person and the whole context. Not solely because you can then intervene, but because you're building a relationship. You're, talking openly and honestly and caring and validating and recognizing how things are different for different people. And people really value that. so there is that reason to do social risk screening. And I think when again, approached with dignity and respect, people's experiences of trust change, their likelihood of adhering to other treatments that may be recommended by that clinician may also really change. The other reason, and I'll just sort of thread the needle here, is that whole category of activities that we talked about related to adjustment. So, patients we don't actually have great data on this yet, but I would say that one of the reasons that the families might have experienced better outcomes in our randomized trial is because clinicians are then using those data to change their recommendations, their treatment recommendations. So maybe they're making it a little bit easier to adhere to treatment by changing the medication regimen or the frequency of follow-up or whatever else, depending on the condition or the context. And that those kinds of changes really change patients' experiences of care as well. So I think that there's some good work that needs to be done related to thinking about what the outcomes are that reflect those pathways that might be influencing health. So that was a very long answer, Ellen, to your question. But in the first answer is what we hear from patients, and what we have heard from patients in several studies is, I just want my provider to know. And then I think that there are these other reasons why we might consider collecting the data or having these conversations that might be leading to the health outcomes. Is that helpful?
Absolutely. Thank you very much. And it fits with the distinction you made earlier about social risk informed versus targeted interventions too, I think. So we have 2 minutes left, and there's one more question here. So hopefully you can give us a quick answer. Oh, there's 2 questions here. But the first one is how to communicate this information to healthcare policymakers. A really important question that you have 2 minutes to answer.
So, in part by doing exactly what we're doing today, I've done a lot of these presentations to healthcare policymakers, many of whom are seeking us out. So this is not, when I started this presentation talking about hype, like I was not kidding. The snowball is so big. We've talked with now maybe 13 or 14 state Medicaid agencies that are reaching out to us, or that we have reached out to ask what they're doing, and hearing about extraordinary sophistication in the ways that they are approaching questions about care integration now. It's high on the radar. And in part because now the focus, even more so now, because the focus of this administration and hopefully everybody is more on equity and how we can better address how we can improve health equity in the approaches that we take in healthcare. So I talk about all of the same things that I just went through in the presentation, but then also in these great questions of why do this? What are the potential benefits? How do we measure the outcomes? How do we focus on both effectiveness research in our decision making, but then also on implementation research? Like, how does this work, and how do you get providers to take these kinds of programs up? I probably do a little bit more of that on the implementation side, because once they've made a decision to do something, then the question is like, how do they know that anybody's doing it? So we're doing some work on quality measures. How to hold health systems accountable for this work. I hope that's a satisfying answer. It's not, the message is the same. The mode of delivery is maybe a little bit different. We do issue briefs instead of academic papers, but yeah, we're doing a lot of presenting more than anything.
Getting the word out in a way people can receive it and hear it. Well, great.
Yeah, short issue briefs.
Sound bites. This has been wonderful today. Thank you so much. And thank you everybody for joining us. And I hope everyone enjoys the beautiful afternoon. Thank you very much.
Bye, everybody. Thanks so much. Have a great day.